Good afternoon, everyone. Welcome to our Regional Geriatric Rounds webinar. My name is Heather McLeod. I'm the Knowledge Translation Specialist for Geriatrics here at the RGPO, and I'll be the moderator for today's session. Before we begin, we would like to take a moment to share a territorial land acknowledgement for Ottawa, where we are hosting today's session. The RGPO offices hosted at the Ottawa Hospital are located on the traditional unceded territory of the Algonquin Anishinaabe Nation, and we are grateful to have the opportunity to present in this territory. Today, Joanna Letemplier and Dr. Simon Wu will be presenting on treatment of behavioral and psychological symptoms of dementia. Dr. Yu is a geriatric psychiatrist working at both the Ottawa Hospital and Geriatric Psychiatry Services Ottawa. He obtained his BSc and MD from the University of British Columbia. He completed his psychiatry residency at the University of Toronto, followed by a one-year geriatric psychiatry fellowship at the Centre for Addictions and Mental Health in Toronto. Joanna is a registered nurse working with the Geriatric Psychiatry Community Services of Ottawa as a case manager. She has worked with the geriatric population since the beginning of her career. She has worked in geriatric rehab, complex continuing care, long-term care, as well as assisted living services for high-risk seniors in the community. Welcome, Joanna and Dr. Yu. We are delighted to have you join us to share your expertise today.
Thank you, Heather, for that introduction. I'm just going to share my screen. All right, so hello, everyone. Welcome. So yes, today's presentation is going to be on the treatment of behavioral and psychological symptoms of dementia. And this presentation was created in collaboration with Dr. Yu and myself. All right. So there's no conflicts of interest to disclose. Dr. Yu completed his geriatric psychiatry fellowship at CAMH, and Dr. Yu was not involved in the development of the drug treatment algorithm for BPSD. So our objectives for today, we're going to review what constitutes BPSD in dementia patients. We're also going to look at contributing factors and some assessment tools as well for BPSD. We're going to review non-pharm approaches for management of patients with BPSD. And then finally, Dr. Yu is going to be reviewing pharmacological treatment for the management of BPSD. So we're going to start with a little bit of background. So BPSD is a spectrum of non-cognitive and non-neurological symptoms that we observe with the progression of dementia. So these three terms you see on the screen are synonymous. Some symptoms may be more identifiable or more commonly present depending on the type of dementia associated and the associated damage to the brain. So for example, a patient with frontotemporal dementia may there may be earlier neuropsychiatric symptoms, such as early loss of social graces and disinhibition, whereas in a Lewy body, we would see visual hallucinations that are colorful, complex, and repeated. So the prevalence, over 500,000 Canadians have dementia, and this is expected to double by 2030, almost double by 2030. And up to 80% of people with dementia develop BPSD at some stage in the disease progression. So what constitutes BPSD? So there are the psychiatric symptoms, so the anxiety, depression, hallucinations, whether that be auditory or visual, delusions, and then also the behavioral symptoms, so that agitation, restlessness, aggression, that could be either physical or verbal, disinhibition, hypersexuality, wandering or exit seeking, sleeping and eating problems, motor symptoms, repetitious questions and actions, rummaging, sundowning, and then also refusal of care. So the effects of BPSD on patients and their loved ones. So there's a decrease of quality of life, increased rate of institutionalization. If the BPSD has any safety issues, such as wandering, exit seeking, if there's an increase in caregiver stress, there's an increased cost of care, and then severe BPSD often requires hospital admission if there's, again, that exit seeking, safety concerns, physical, verbal aggression behaviors. So in order to treat the behavior, it's really important to understand the associated losses with dementia, as well as the external factors that can be a source or contributing to BPSD. So I'm going to start with the 8 A's of dementia, which most of you are probably very familiar with. So we're going to do a brief overview of those. So the first one is anosognosia. So that's the loss of insight. So a patient may overestimate their abilities, demonstrate poor judgment, poor problem-solving planning. This could lead to safety issues, and they may be unaware of the consequences that this has on others. And then there's the very most known symptom, so amnesia, so that loss of memory. This happens in reverse order. So past memories may be triggered by a present stimulus. The patient lives in the present, but only has access to information from the past. And even though they lose memories, they retain emotions. So that's a very important tidbit I'd like everybody to leave with. And then there's aphasia. So that's the loss of language. So that could be receptive. So they can't comprehend the language. That's associated with the Wernicke's area of the brain. And then there's also expressive aphasia. So they can comprehend, but they can't express language. That's associated with the Broca's area of the brain. There may be a reversion to their maternal language or their first language. And they're still responsive to nonverbal communication, so facial expressions, gestures. The next A is agnosia, so that's a loss of recognition, and this is despite intact senses, so vision and touch, for example. So they may not be able to recognize objects, faces, including their own, words, somatosensory loss, such as objects via touch. They forget the last people who entered their life, so in reverse order. So examples of this could be thinking a pill crusher is someone knocking on the door, or a cat meowing is a baby crying. And then there's apraxia, so that's the loss of purposeful movement. So loss of task sequencing, and this is part of the executive function loss. Altered level of perception, so this one speaks for itself. So this includes depth perception, visual distortions causing misperception of items. There's apathy, loss of initiation. This symptom actually can often be misinterpreted as a symptom of depression, but the difference is that the person will engage in the task or activity if encouraged, and there will be joy associated with that. So that's the difference. It's just that loss of get up and go, of initiation. And then the last day we have here is attention deficit. So that inability to sit still for a meal or maintain attention on a task for long periods of time. So there's going to be damage to executive functions, judgment, insight, decision-making, social cues, that filter, and then also damage to sleep-wake regulators of the brain as well. And then there's all the environmental, social, and biological contributing factors to BPSD. So for anybody who's taken a GPA course, the Gentle Persuasive Approaches course, so the reigning message is all behavior has meaning. So often there's an unmet need, or the environment is unable to support or meet their needs. That could be related to toileting, hearing, vision impairment, and the person can't communicate that need. So for example, removing their clothing because they're too hot. We might see that as a behavior if they're not able to communicate that they're too hot, for example. There may be overstimulation in the environment in a group activity, for example, or a busy dining room. Or there may just be boredom, not enough activities or engagement to keep them occupied. The way the caregiver responds to a behavior situation might worsen the behavior. So that could be body language, it could be the way the message is spoken, or arguing with the person. So that all can perhaps worsen a behavior, trying to redirect reality also. There's also physical ailments that can contribute to BPSD. So that could be an infection, delirium, constipation, dehydration, pain. Again, they can't communicate that need. A medication side effect, a mood component, so that fear, anxiety, a sense of loss of control. They don't feel safe, heard, listened to, or understood. Or a change in environment, a change in caregiver, an unpredictable situation, or isolation. So we're going to touch upon some assessment tools. So first, it's really important to know the person's baseline in terms of their cognition. And Dr. Yu is going to touch upon some assessment tools related to that later on in the presentation, related to assessing a person's baseline. One tool that I find very holistic and effective is the PIECES tool. So that's a 2-day training that you can take. It's a whole program. And this model provides a shared understanding of the often multiple underlying causes of behavioral expression and associated risks. It can help recognize needs, build on the person's remaining strengths, and consider the person's physical, intellectual, and emotional health, supportive strategies to maximize capabilities, and also takes into consideration the individual's social and physical environment and the social self, so their cultural, spiritual life story. So very holistic. And then there's also the BSO-DOS mapping. So this tool is very helpful to identify patterns of behavior and look at triggers and really help us tailor our approach to the person and to the situation that's happening. So another thing I want you to think about is really considering whether the behavior is new or different. Does it interfere with their quality of life? As long as it doesn't interfere with the patient's quality of life or the person's ability to interact with the world around them, sometimes it can be best not to interfere. So sometimes what we might perceive as BPSD is actually a learned behavior or skill that's ingrained in the procedural memory of the patient. So an example of this might be a retired nurse now with advanced dementia living on a memory care floor, for example, and she's wandering at night, going in and out of patients' rooms, not really disrupting anybody, just kind of wandering around, going in and out of rooms. But for her, it's an ingrained procedure that she's done her whole life. Checking on her patients, her nightly rounds. So this is kind of really reinforces the message of knowing the person and knowing their history and who they were, as this might just be an integral part of who they are. So non-pharmacological approaches in terms of the assessment. So we always want to use a problem-solving approach, maintain that high index of suspicion for any physical ailments such as pain, discomfort, other symptoms that they might not be able to express. And once all those things have been ruled out, we want to choose non-pharmacological approaches based on the displayed behavior, identifying triggers or patterns, and tailor the intervention to the person. So this is where the BSO-DOS can be very helpful as well. So in terms of communication, we want to be kind and patient, use a non-confrontational approach, try to put yourself in the person's shoes. Remember that their reality is different than ours sometimes, and they're not attempting to be deliberately difficult. We want to avoid a punitive approach, trying to argue or reason with the person. If they're in a situation where they're overstimulated or displaying inappropriate social behaviors, such as a sexual behavior, we want to avoid, again, the punitive approach and remain calm, redirect to a private area, such as their room. And then also keeping in mind, if you can't remove the person from the situation, sometimes it can be easier to remove bystanders to foster a calm environment if you can't move the person. We want to use a positive, supportive, nonverbal communication. We want to convey calmness, reassurance, kindness in our facial expressions, body language, tone of voice, gestures. And then in order to redirect, we want to validate, reassure, acknowledge what they're feeling, join them, and then to be able to distract. So an example of using this technique would be a patient who's lost their purse. They're very distressed because they carried a purse for 20 years and they don't remember that they haven't had one for the last 10 years. And so they're frantically looking for their purse. So you kind of that must be very frustrating for you. I see you're very distressed by this. You're acknowledging, validating, reassuring, we're going to find your purse, and then join. So let's go look for your purse over here where people are eating in the dining room. And then once you're in the dining room, you can redirect to a different activity, such as, oh, would you like a cup of coffee while we look for your purse? So skipping the join portion of that algorithm can sometimes make it so that you can't redirect, and it feels like you're dismissing their concern. So, oh, that's really sad. I'm so sorry you can't find your purse. Let's go get a cup of coffee, for example. And also making sure that your language is not reduced to perhaps like using pet names or not using adult language, unless the person expressively likes to be called dear or sweetheart. We want to avoid doing that so that we don't sound condescending or, kind of disrupt that therapeutic bond. So non-pharm approaches that we can put in the environment. So we want to modify the environment to set them up for success as per whatever stage they're at in their disease process. So if they're distressed by looking at the reflection in the mirror because they no longer recognize themselves, we want to just literally remove or cover the mirror. So we're just removing that trigger from their environment. Keeping visual cues can be very helpful, especially in the earlier stages of the illness. Reminder notes, schedules, consistent daily routines. Minimizing distractions during care tasks, so turning off that radio, the TV, so the focus is on you. In terms of sundowning, so keeping the living areas well lit in the evening and closing the blinds prior to the sun setting to help with that transition. And then using colors to contrast appropriately in the dining room. For example, if you have a white tablecloth on with a white plate and mashed potatoes, it can be really hard to distinguish where the food is for some. So you might want to contrast the colors a little bit to help recognize and set them up for success. And then finally, some techniques in terms of non-pharm approaches. So again, if you've done the GPA training, you might recognize a few of these from that training. So the stop and go technique. So we want to evaluate if the care needs to be done right now, immediately, or if there's some BPSD that's happening, agitation, perhaps a little bit of aggression. Is it safe to just stop and return at a later time? We want to perhaps demonstrate the use of objects to people, for example, their toothbrush or hairbrush, showing them how to use it, helping step by step, providing simple instructions, and allowing the person to finish a step independently if they can before introducing the next. In terms of dementiability techniques, if you've heard of that, using picture symbols at the bedside or dressing area that demonstrate the sequencing of tasks, so to put on the pants or shirt, that sometimes can be helpful earlier on in the disease process or even later to help a comprehension of what you're asking them to do. The hand-over-hand technique for meals, for example, bringing the spoon to the mouth, engaging the person in meaningful activities that they would enjoy. Again, tying into that, knowing the person being very important, that personhood part of non-pharmacological management. So that could be, household chores, rummage box, twiddle muff, whatever the person really enjoys and to their level of abilities. We could try to incorporate daily exercise that fits their capabilities, so to get rid of all of that extra energy, and also providing education of family and caregivers about what we observe, the disease process, and getting their input is very important as well, because they know their loved ones very, very well, and often they want to be involved for the most part. So that's really important as well. Lastly, I included this little quote because I think it's very relevant to dementia care and what we do. So they may forget what you said, but they will never forget how you made them feel, really tying into that emotions remain piece. So I thought that's very relevant. So I'm going to pass the presentation over to Dr. Yu, and thank you very much.
Thank you, Joanna. I think I should be able to flip now. Okay. So thank you everyone for joining us at our presentation today. Now that Joanna has spoken about the non-pharmacological approach and interventions for BPSD, I'd like to present on more the pharmacological approach, medication-based treatment, with a focus on a medication algorithm developed at the Center for Addictions and Mental Health in Toronto with their geriatric psychiatry team there. I just want to first introduce this algorithm. It was developed on the inpatient geriatric psychiatry unit at CAMH. It's a initiative that they've had for the past couple of years now. They're in the process of looking into the application of this algorithm for long-term care settings as well. But the first thing to keep in mind is that this is an algorithm that is so far validated in an inpatient setting, but they're trying to see if it can be validated for other settings as well. So there have been more and more treatments that have been developed over time, medication treatments for BPSD, and from this development has arisen a need for a more algorithm-based approach to the medication management of BPSD. The different treatments, different medications have significant variability in terms of the quality of the studies that validate their effectiveness. And a lot of the medications options are out there do carry significant risk of side effects and toxicity as well. Of note, there is a Health Canada warning from 2004, for example, for antipsychotics when used for older adults with dementia, that there is an increased risk of mortality and stroke. And that's just one example of the increased the risk of side effects for some of these medications. And so the goals of developing an algorithm-based medication treatment for BPSD would be, first of all, to improve outcomes from the treatment, to try to achieve more rapid symptom control, and to hopefully decrease the length of stay for patients in the inpatient setting. It is also, the goal is to reduce the rates of polypharmacy, which are unfortunately very common for seniors with dementia with BPSD who are on medications for that, and to try to achieve a higher caregiver and patient satisfaction. And so what also an algorithm, medication algorithm is hoping to achieve is to have easier kind of optimization of drug dosing, the frequency at which follow-ups are conducted, standardizing the length of medication trials, and to have clear decision points where the dose titration or medication switch can be decided. So to essentially have everything in a very straightforward, step-by-step, clear algorithm, essentially, to try to standardize care, make sure that the same medication treatment is being provided to the same quality and standard. And so the medication algorithm that was developed at CAMH, it is validated for Alzheimer's and vascular dementia only, because these two subtypes of dementia have the most evidence-based treatments. They're the most well studied, and also the medication algorithm also only applies to specific forms of BPSD in terms of agitation and aggression for patients with Alzheimer's and vascular dementia. So it has a very specific target population. And medications also, there's a clear indication for when medications should be used and when medications should not be used. And so the use case for medications, the two kind of fundamental use cases is either that the BPSD, the behaviors, is causing a significant risk of harm to either the patient or to people around them, or if the symptoms are causing a significant level of distress to the patient and the non-pharmacological or behavioral interventions are not sufficient to address these issues. And so the process by which they developed the algorithm is they looked at 15 existing clinical guidelines for BPSD and did the systematic appraisal, looking at the strength of the evidence, the time to the onset of effect, tolerability profile and side effect profile, likelihood of drug interactions, as well as potential benefits for other conditions as well, other comorbid conditions such as anxiety. And here just a table to illustrate varying kind of degrees of quality that they found for each of these treatments. And to talk a little bit more about eligibility criteria for the medication algorithm as well, as before starting the medication algorithm, before even considering the use of medications, there are several important things to do, including ruling out medical causes of agitation and aggression, which, especially for patients who are coming into an inpatient setting, are extremely common to see that there's constipation or there's an infection or some kind of physical issue that is oftentimes easily addressed but can be a major contributor to BPSD and to behavioral disturbances. And what we do see a lot of time is that when these physical health issues are addressed, that the behaviors actually improve or go away completely. Pain management is another common physical issue that can worsen behaviors. As I mentioned earlier, it's important to make sure that the medication algorithm is being applied to patients for whom it's been validated, specifically patients with Alzheimer's and vascular dementia, and to make sure that the treatment indications are there. There's agitation and aggression that are causing significant safety concerns or causing significant distress that is beyond the ability of non-pharmacological interventions to manage. So as part of the formal protocol, the formal medication algorithm, they do recommend using a whole bunch of different batteries and baseline assessments. In actual clinical practice, these may or may not be of as much relevance, but for the purposes of the study and the development of this algorithm, they did use many different measures, including the MPI. The Clinical Global Impression Scale is used quite a bit, and that's actually I'm not sure what everyone's familiarity is with that scale, but it's actually fairly straightforward. Essentially, it just translates the amount of improvement, the clinician's impression of the amount of improvement, into a number scale. And so there's the severity scale, and then there's the improvement scale. And they look at other kind of measurements for tolerability, including the Barnes-Akathisia scale, the abnormal involuntary movement scale. Those are all looking more at the side effects, tolerability profile, especially for antipsychotic medications. So these are kind of the baseline recommendations that they recommend. And baseline investigations as well, including electrocardiogram to establish the QTC, and that's because a lot of the medications on the medication algorithm have potential of QTC prolongation. So that's important to know. Baseline investigations also including CBC, electrolytes, creatinine, and specifically fasting glucose and lipid profile are specifically relevant, again, to the common side effect profiles of second-generation antipsychotics, as there can be derangements in glucose and lipid profile from those medications as well. So once the patient has been deemed to be eligible for the medication algorithm, it happens in multiple phases. So the first phase before any medication trial is considered is the medication cleanup phase, and also the behavioral observation phase. It's important to know that just because someone is going into the medication algorithm doesn't mean that behavioral interventions or non-pharmacological interventions are obsolete. It means they are still very much relevant, and they should still be used to their maximal capacity. So non-pharmacological interventions should continue to be used in all three phases of the medication algorithm. But the cleanup phase, it consists of a 10-day period before starting any medication trials, and it is composed of a concurrent medication cleanup and a baseline assessment. And the algorithm has specific guidelines for different categories of medications. So starting with the category of cognitive enhancers, of which people may be familiar, there's donepezil or Aricept, rivastigmine and memantine. These are some commonly used cognitive enhancers. And the recommendation as per the algorithm is that the cognitive enhancer should be continued unless there is clear indication that their side effect is causing or contributing to BPSD. If there is no indication of adverse reactions, then the dose of a cognitive enhancer can be optimized during the medication algorithm, during the medication trial, but no new cognitive enhancers should be started as part of the medication algorithm. For non-benzodiazepine medications, the recommendation is that if they were started to address BPSD, to address behavioral disturbances, that they should be tapered and discontinued, so that we can start at a blank slate. And that's partly to reduce the occurrence of polypharmacy, and also to make it more clear what is the effect of each of subsequent medication trials. It's harder to tell that if there's a existing medication that's on board that could also be playing a role that may be partially effective. So there's multiple rationales for that. And so if the medication was started for BPSD, it is recommended that they be tapered from day 3 to day 10 of the algorithm. But if the medications were not started for BPSD, but were started for another condition, such as depression, anxiety, et cetera, that they should be continued, they should not be modified. For some reason, it's not advancing. Joanna, are you able to advance the slide? Oh, sorry, I think it just got frozen for a second. There we go. And then the last category is for benzodiazepines and Z drugs, such as zopiclones and zolpidem. Benzodiazepines, and some of you may be familiar, have significant safety concerns, especially for elderly populations and for dementia populations. They do so. All of these medications carry significantly increased risk of falls, of contributing to confusion, delirium, and worsening cognitive impairment, and they also have significant risk for dependence as well. And so unless there is a clear recent evidence of an insurmountable difficulty in stopping one of these medications, they should be tapered, but tapered slowly, because a lot of the, especially the benzodiazepines, if tapered too quickly, can increase the risk of seizures, and the withdrawal syndromes can also be very difficult, challenging for the patient. So they can be tapered slowly, but for these medications, the primary guidance is to taper and discontinue them. And then during the initial phase, the cleanup phase, the focus is on using PRN medications to manage agitation, aggression, and other difficult behaviors. And so the first line PRN is trazodone 25 milligrams every hour as needed, up to 300 milligrams in non-frail patients, or 150 milligrams in frail patients. It is the first line PRN primarily because of its tolerability and safety profile. So it's doesn't have any affinity for cholinergic receptors, has no anticholinergic side effect. It's quite an effective medication for inducing sedation and reducing agitation. So it's really the first line because of superior efficacy and tolerability. And lorazepam is a second-line PRN, but the thing to note is that it's really used only as a last resort in cases where the trazodone is not tolerated, if there's some kind of strong contraindication to using that. And the recommendation is for 0.5 milligrams of lorazepam every 4 hours as needed. And as I mentioned earlier, it carries significant increased risk of falls, worsening cognitive deficits, tolerance. So it's really reserved for for extreme situations where there's a high level of agitation or aggression that's not responsive to trazodone, or if there is a contraindication to trazodone. And so at the end of the 10-day cleanup phase, as per the protocol, they recommend repeating the clinical impression improvement scale, and comparing that to the baseline, repeating the neuropsychiatric inventory. And if the CGI score is 1 to 2, which is significantly improved or improved, then the patient can actually exit the medication algorithm at that point before even starting a medication trial. And this happens for a substantial minority of inpatient cases where they come in with significant behaviors, but a physical issue is addressed, or the environmental change is effective, or the non-pharmacological interventions are effective, and their behavior settles, and they do not end up needing a medication trial. So this is a very important point, that not everyone who goes through the medication algorithm actually ends up receiving a medication trial. A substantial minority of them improve solely with medical cleanup and behavioral interventions. But if, this is just a quick summary of what I just discussed. This is pulled straight from the algorithm itself. But if the patient does still end up needing a medication trial, then they have a very clear step-by-step, first line, second line, third line, etc. Guideline for how to approach medication trials. The important thing to remember is that any step in the medication algorithm can be skipped if there is a contraindication to that specific medication. And any medication can also be stopped if there's significant tolerability concerns and continue to the next step of the algorithm. And so there's also several decision points that are built into the medication trials. So the decision point happens at day 7 to 14 of once you have achieved the initial target dose of the medication that you're currently trialing. And with repeat of the scales, again, if the clinical global impression improvement scale is either much improved or very much improved, then the trial is considered successful and the patient can exit the algorithm. If the CGI-I scale shows minimal improvement or less improvement than that, a higher number is bad, then there is an option to titrate the dose up further to a final target dose at the day 21. And then if by day 21, if the clinical global impression scale is 4 or more, which means minimal improvement, then the trial is considered unsuccessful and the patient should move on to the next medication in the algorithm. Specifically only for risperidone and quetiapine, if at the 21-day period that the CGI scale is 3, that there can be an additional 21-day extension for the trial. And again, if the CGI is 1 or 2, which is again much improved or very much improved, then the trial is successful. And then at decision point 3, which is after the second 21-day extension for risperidone or quetiapine only, there's again a repeat of the CGI scale, and depending on whether or not there is significant improvement or not, the patient either moves on to the next medication in the algorithm, or the trial is successful and they exit the algorithm. I just want to quickly go through each of the medications on the algorithm by order of their priority and in terms of first line, second line, etc. So the first line medication in the algorithm, the first one to recommend it to try, unless there's a clear contraindication, is risperidone, which is an atypical antipsychotic, and the dose ranges between 0.5 to 1.5 milligrams for non-frail patients and 0.25 to 0.75 milligrams for frail patients. And risperidone has the strongest evidence out of all the medications available for management of agitation and aggression, as well as psychotic symptoms in Alzheimer's and vascular dementia. And it does have Health Canada approval for these symptoms as well. But as I mentioned earlier, there is an increased risk of mortality from all causes of about 1%. This is what I tell families and patients. While a senior with dementia is on a medication like risperidone or just really second generation antipsychotics in general, that there is a 1% increased risk of mortality from all causes while they're on that medication. So this is important to inform them in terms of the risk benefit, kind of weighing the risk and the benefit of the medication. Step 2, or as well, second line medications, there's actually 2 options. The first option is quetiapine, which is another atypical antipsychotic, and the dose range is between 25 and 200 milligrams for non-frail patients and up to 100 milligrams for frail patients. Quetiapine has a weaker evidence base than risperidone, but still has a statistically significant effect from meta-analysis. There are some potential advantages over risperidone in that it has a shorter time to onset, and it may have some efficacy for concurrent symptoms as well, especially for anxiety. I think it might be lagging again. Okay, there we go. And then the second option as the second line medication is Abilify, another atypical antipsychotic, dose up to 12.5 milligrams for non-frail patients and up to 10 milligrams for frail patients. And similar to quetiapine, has a smaller evidence base than risperidone, but remains superior to placebo in meta-analyses. It does have a different mechanism of action compared to risperidone or quetiapine because it is a partial agonist of the dopamine receptor as opposed to just an antagonist. And so it may have a better chance for effectiveness in people who have not responded to risperidone. Step 3, or the third line medication, is carbamazepine, which is a anti-seizure medication and mood stabilizer, up to 200 milligrams twice daily for non-frail patients and up to 100 milligrams twice daily for frail patients. And carbamazepine has some efficacy from randomized trials, but the evidence is a bit more mixed. And the main concern with carbamazepine is that it has a very high likelihood for drug interactions, as it is a powerful inducer of the cytochrome P3A4 enzyme. And so it can cause reduced drug levels for many other medications that go through that metabolic pathway. And it has some rare but potentially serious side effects as well. So carbamazepine oftentimes in clinical practice is skipped because of these concerns. Fourth line medication is citalopram, which is an antidepressant. The maximum dose is 20 milligrams for patients over age 60 because of the risk of QT prolongation. And so that's 65. So that's actually from a Health Canada directive. Is that the maximum dose is 20 milligrams daily, and it carries significant risk of QTC prolongation. One of the potential downsides of citalopram, as with other antidepressants, is that it has a longer time to onset of effectiveness. And then further down, fifth line would be gabapentin. Is an anti-seizure medication up to 600 milligrams 3 times daily. And at this point, the evidence starts becoming pretty weak. So it only has some case reports and case series that's suggesting effectiveness. It is effective for comorbid anxiety as well. One potential advantage is that it's not metabolized by the liver. It's purely excreted through the kidneys. So if there are medication interaction concerns for the liver, or if the patient has hepatic impairment, it could be an advantage for you to use gabapentin. But moving at this point, kind of this low down in the algorithm, the evidence for effectiveness becomes relatively weak. Sixth line is prazosin, and it's an antihypertensive medication. And again, similarly, low amount of evidence for effectiveness. And the main concern, side effect wise and tolerability wise, is the increased potential for postural hypotension. For patients. And then at the end of the algorithm, if there is 2 medications that have been tried and they both have a partial effectiveness, this is the point where the medication algorithm recommends combining 2 medications. So this is the only case where they would actually consider polypharmacy to be acceptable, or we consider a combination of medications to be acceptable. Otherwise, there should only be 1 medication on board at a time for management of BPSD. And electroconvulsive therapy is also kind of as a last resort option for managing severe treatment-resistant BPSD, but no controlled trials exist so far for ECP. And then at the end of the algorithm, they do recommend repeating all of the baseline assessments as well. And so that comes to the end of the medication algorithm portion. And I'll hand back to Joanna, and we can do a quick clinical vignette just to kind of get people to think and maybe try to apply some of the information that we just described.
Thank you, Dr. Yu. Heather, do we have time for the clinical vignette, or would you rather just go straight to the
Well,
Q&A?
there's just one question in the Q&A. So I think we have time for the vignette. Thank you.
Perfect. Okay, so here we have Mr. J, picture generously provided by Dr. Yu. So Mr. J has a diagnosis of mixed dementia, so Alzheimer's and vascular. He's in the moderately severe stage of this illness. So he lives on a memory care unit in a retirement home. His wife was visiting him daily, but in the last few months, she has been trying to cope with her own health issues, and so she visits when she can. So Mr. J used to participate in the activities on the unit with his wife, and she would also take him on walks outside. So Mr. J has been sleeping more during the day. He doesn't leave his room unless prompted, such as for meals, and also bathing and care has become a challenge. He often refuses help and become verbally and occasionally physically aggressive with staff. So his health history includes poor hearing. He has hearing aids, but he often removes and misplaces them. Hypertension, high cholesterol, chronic back pain due to degenerative disc disease, and benign prostatic hyperplasia. So I'd like to have your thoughts. If you could type in the chat, what do you think are some potential triggers for this behavior in Mr. J? Yeah, I see pain, change in social situation, loneliness, and boredom. Yep, absolutely, absolutely. Loss of assistance from spouse. Yep, his spouse seemed to be a huge support for Mr. J for sure. Yep, hearing. His hearing is decreased, probably can't hear what people are trying to communicate with him, especially during care. Absolutely, yes. For sure, absolutely. It could be, yeah, definitely his wife no longer coming in as often could be a huge trigger. Poor hearing, pain, any other underlying medical conditions. Might not think he needs help as well, that anosognosia we talked about. So any non-pharm recommendations that you might have for the staff and family? Apathy, absolutely. Yep, someone wrote apathy there. Yep, trying to engage him in more activities. Yep, time lighting of the room, leaving the curtains open so to help him orient to the time of day, resuming walks and social engagement. Yep, for sure, getting him back into kind of the routine that he had that had been working very well for him. Exercise for pain relief. Yep, specialty seating, maybe getting an OT in there. Absolutely, yes. Perhaps we can look at maybe other family members that might be able to visit while his wife is away. If he has children, using communication tools, absolutely. And then in terms of pharmacological recommendations, does anybody have any thoughts on that? And I also see pictures of his wife and family. Yes, absolutely. Plaster that all over the walls. That's a really good suggestion. Review what is happening during care and design a script guidelines for caregivers. Yep, for sure. Dr. Yu, do you have any thoughts on perhaps the pharmacological side of things?
Yeah, so because so thinking about eligibility, as I had described earlier, the mixed dementia usually he does meet the criteria for having mixed Alzheimer's and vascular dementia, and in thinking about other eligibility criteria, that there is significant physical aggression, so that's one checked off as well, and if he is demonstrating significant distress as well, that's another criteria that is checked off. And so as I was describing earlier, before considering any medication trials, it is important to, again, rule out and address any underlying physical contributors. So basic investigation, abdominal x-ray to determine if there's fecal loading, urinalysis to determine if there is an infection, and this would be happening, again, this is thinking more in terms of an inpatient context. If all physical issues are addressed, if non-pharmacological interventions have been optimized, but there is still significant agitation and aggression, then risperidone would be the first line treatment, starting with a trial of that, and then following the algorithm if risperidone is unsuccessful.
Excellent, thank you so much. Yes, does anybody else have any other thoughts on that? What would happen if Mr. J wasn't brought to hospital pharmacologically?
Yeah, so we do also, even though it's not formally validated for outpatient settings, it's still okay to follow the algorithm in terms of the sequence of medication to try. Typically, for an outpatient setting, the physical investigations are dependent on the family medicine, on our family medicine colleagues to make sure that that these issues are addressed, that there's investigations done. And then we start at the same starting dose, but the titration frequency is much slower. So typically we do an adjustment once every 2 or 3 weeks, just because of the frequency of monitoring is, of course, lower in the community. Usually people in the community have less severe behavioral disturbances. If the behavioral services are extreme, then they should be in the inpatient setting anyway. But if they're not so severe, then we usually have a bit more time to stretch out the medication titration to really make sure that the tolerability is as good as they can be, and to try to do the medication trial that way. And PRNs definitely can be helpful. PRNs oftentimes, unfortunately, are challenging to administer in the community. They are much more straightforward to do in an inpatient setting. If the family is on board and they're really on top of it, they can obviously give the PRN trazodone. If a patient is in a retirement home, that can be more challenging. PRNs definitely have a role, but the actual practical administration of PRNs is more difficult in the community.
Okay, do we have any other thoughts on this case? Thank you. Okay, I think we can move on to the Q&A, Heather.
Great. Yeah. So we have a few minutes to please type your questions in the Q&A. We have one here. Is it common to use lorazepam as a second line?
So it's rare that we use lorazepam. What we actually, we have a different protocol here at TOH where I also primarily work, where we actually have, in terms of PRNs, a first-line PRN, second-line PRN, and third-line PRN. Trazodone is still the first line, but second line, we actually typically go with risperidone. And the third line would be an intramuscular loxapine at a low dose for severe agitation and aggression, or cases where the patient is refusing oral medications. So this is a separate protocol that we follow at TOH. It's developed independently from the CAMH protocol, but we do use this protocol. Again, I think there's a lot of concern just in general about these tolerability, the side effect potential for lorazepam. And so the only situation in practice where we would really use lorazepam is if the patient has severe Parkinsonism and they are not able to tolerate anything with any kind of dopamine antagonist, so which would kind of rule out a lot of the antipsychotic medication. Definitely would rule out risperidone and loxapine. So only in these cases would we really consider using lorazepam.
Great, thank you. And we have another question here. When is physical aggression occurring? Perhaps, a pre-care PRN. That was for the case, I guess. Yeah.
Yeah, pre-care PRNs can be helpful as well. Oftentimes it's not so much of the medication, question is not so much the effectiveness of the medication, it's more the practicalities of administering PRNs, because they do take about an hour to fully kick in. And so this requires a lot more pre-planning and structure. And especially if someone's in the community, for example, they may have a PSW coming in to visit them. It's just an extra step, like if for the family or the PSW to help the patient take the medication, but it has to be given an hour before. It becomes a lot more complicated that way.
Great, thank you. Is there somewhere that providers from other facilities can access this algorithm to be implemented at other sites?
I don't know if this is the algorithm itself is actually it's freely available online as a publication. They have put this out there as a publication. So I don't think there's a paywall or anything. Anyone should be able to access that. It's called, I'm just going to pull up the specific title. It is called the Sequential Drug Treatment Algorithm for Agitation and Aggression in Alzheimer's and Mixed Dementia. I can type that into the chat if people want to have that as a reference. And if they want to look at the article themselves, I'll just copy and paste that here.
Great, thank you. Another question, can you comment on the risk of akathisia with Abilify? Is there more risk in this population or similar to general population?
So there's not really any evidence that seniors are more likely to have akathisia from Abilify than the general adult population. So it's really kind of more following general guidelines of geriatric dosing. We obviously start at much lower doses for compared to a general adult population, and the maximum dose is lower as well. And that in itself does reduce the risk of akathisia. It's not in practice, it's not something I see commonly. It's dose dependent as well. So the higher the dose, the higher the likelihood for akathisia. But I think it's mostly because of the lower doses that we use for geriatric patients that it's not as common that we see it. Great.
Well, I don't see any other questions here. So I just want to thank you both for such a comprehensive review of this topic. It's an area where we all want to sort of develop our skills in. So I appreciate both the pharmacological and non-pharmacological examples of how perhaps we can support our older adults who are struggling a bit. And so we want to thank you for today. And I believe we'll have the recording and or slides up within a few weeks on our website. We just want to let everyone know that we have our an evaluation survey, if you can please fill that out. And on our next slide, we will also have a list here of, again, this year, we're focusing all our monthly rounds on dementia-related topics. So we have these ones listed here from December to April. And just to let everyone know, we have Dr. Kenneth Rockwood coming to speak on December 14th. Some of you may know him from the clinical frailty scale. So just wanted to let people know he's coming on, virtually on December 14th. And we have our next geriatric education series at the end of February. So again, thank you everyone for attending, and thank you again, Dr. Yu and Joanna.